Excellent. Great. So again, welcome everyone. We're very grateful and happy to see you all here today. Today is a very special day, March 8th, International Women's Day. It's really important to emphasize the role that women play in our healthcare system as innovators, as leaders, as colleagues. And what better way to celebrate than having one of the most important, I would argue, and I'm sure everyone would agree, Professor Mojgan Hodaie to our event, a surgeon scientist, a distinguished leader, mentor, colleague, and friend. So without further ado, I will introduce our speaker for the evening. But before I do that, I also want to mention for those of you who came in just now that the structure of this presentation would be about 45 minutes of seminar from Professor Hodaie, followed with a question and answer period, and the link you can find on Slido, and we will be moderating the chat for you. Okay, great. So now to the beginning of our first Women in Neurosurgery series. Professor Mojgan Hodaie of the University of Toronto Department of Neurosurgery has been a staff surgeon at the Toronto Western Hospital for several years with expertise in stereotactic and functional neurosurgery. She's a co-director of the Gamma Knife Center. Dr. Hodaie runs an active laboratory centered on structural MRI imaging with a focus on neuropathic pain. She has published prolifically and is a seminal leader in the field and has been recognized as a global leader in functional neurosurgery. And in celebration with the International Women's Day today in March, we're very happy to have this conversation with her. I'm very pleased that she will be sharing some pearls of wisdom reflecting on her distinguished career as a neurosurgeon scientist. Professor Hodaie, the floor is yours now. Thank you.
Well, thank you so much for inviting me. It's really nice to be with all of you, and I have to say I would like to keep this conversation sort of casual and comfortable. It's not going to be super formal. Let me start by sharing my screen. There we go. Can you see it? Okay, so I guess maybe I'll start by saying why is it that I chose the field of neurosurgery. I've always been interested in medicine, not exclusively. I have to say that for a while there was a very tight competition between medicine and chemistry. And I almost switched my undergrad from biochemistry to just go on and stick to organic chemistry, except I was missing one math credit and I would have fallen behind by 1 year. So I decided not to do that. But nonetheless, medicine has always been a big desire of mine. And I really had no idea what it meant to be in academia and what were the steps that you had to take for academic success and so on. And really no one in my family is in the field of academics. Everyone, obviously, education has been a very big thing, always for my family, but not in an academic path. And my interest in neurosurgery really sparked much later. I did my med school at Queen's and then my residency at the University of Toronto. And I think, you know, the pathways and decisions that we make are not necessarily ones that always follow a similar pattern. So I think that's important to know. And I have to say the role of mentors is, in my view, crucial. But I'm going to actually, you know, this is sort of a formal way of telling you why I started, or why I chose neurosurgery. And I'm going to tell you what was the informal way of why I chose neurosurgery. And that is because of my father. So this is my father holding my first daughter when she was just born. And my father had hemifacial spasm, which you guys, if you've done your neuroblock, you might know, which the cranial nerve 7 just twitches and it gives patients constant spasm, which is rather annoying, and it can be rather, you know, disfiguring with time. And if you look at his face, you can see a little bit of facial asymmetry. After he had it for a very long time, it actually did result in some cranial nerve 7 weakness. So in his quest to find someone to help him with this condition, we met Dr. Andrew Talala, who is my ultimate mentor, and he became my father's doctor. And even though my father decided not to have surgery, Nonetheless, the connection between myself taking him to places because his English wasn't so good, and Dr. Talala, who was at a time in his career which was effectively retired, and it just set up for a true relationship between a mentor and a student. And sometimes I think, had Dr. Talala been a podiatrist, I probably would have become a podiatrist as well. Because his character and his strength and his personality were so meaningful to me and really shaped my medical career. And I think this is something that I've come to realize with time, how important it is to hold one in a position that to realize that really what you tell your students or what you tell the people that you interact with really carry and might carry for years and years to come, and as it did for me. And from there, I went on, and after my medical degree at Queen's, I got in my choice at the University of Toronto, and then I was asked to stay here as staff. And there, my career in academic neurosurgery started. And really, academics involves 3 specific areas altogether: so surgery, research, and education. So within all of these, to one degree or another, we're all obviously deeply involved. And for some of us, one area is a huge passion, or multiples of one area are a huge passion. And my subspecialty field of work ended up actually not perhaps in a subconscious way, but not in a very conscious way, ended up being the subspecialty Dr. Talala had as well, which is thoracic and functional neurosurgery. And I became deeply involved in the management of this condition called trigeminal neuralgia, which is a very, very severe condition that affects severe pain condition that affects the face. And I treat these patients with microvascular decompression, with gamma knife radiosurgery, with peripheral procedures, and neuromodulation cases as well. And again, this condition is, we think that there is a blood vessel that is compressing the trigeminal nerve and resulting in significant microstructural changes in the nerve and these pain signals that fire. So you can see, for instance, in an MRI here, the trigeminal nerve, which is this tiny, tiny nerve over here, tiny but very, very strong and potent. And this one is just coursing happily. And over here, you can see that there's actually a loop of blood vessel that is kinking the nerve and almost distorting it. And what we do is that we actually travel through this corridor in between the brain and the bone, the cerebellopontine angle, to reach this nerve. And in this corridor, there's it's like a cavern where there's a whole bunch of nerves. So you have to be sure of where you're going and keep an eye on things. And I'm going to show you a brief clip of what a microvascular decompression is like. And you can see here, which I'm going to pause it. So I don't know whether you can see my mouse, but this distance, the white patty that you see, is 1 centimeter. So that gives you an impression of how zoomed in the view is for the microscope. And then you will see, so everything's beating with the heartbeat. Cranial nerve 7 and 8 are here. And this is cranial 5, and you see how it's flat and it's really sort of distorted. And very soon I'll be pulling out a big loop of blood vessel that is just kinking that nerve from underneath and really irritating this this nerve. And you can see we have to dissect. So deep to this blood vessel, you can see the area of the pons. And here's the blood vessel that is now out of the way. And what we do is that we put a piece of Teflon so that the irritation stops. And that essentially concludes the procedure. So at this point, I've done now over 1,000 of these cases, which is, I have to say, it was a little bit of a surprise. And this made news what seems like a century ago, but it was only about a year ago. before the pandemic, and this is added on top of the other cases that we do in terms of neuromodulation for patients with Parkinson's disease and movement disorders, where we record the deep circuitry and the neurons in the brain to find out where we should put these electrodes, and put essentially pacemakers for these patients. These are brain pacemakers. And we help them. So for instance, look at this woman. She has essential tremor. I hope you can hear the sound. And her hand is shaking really bad, but then when we stimulate, we are able to map exactly where it is that we should put the electrode. And it also helps her with control of her tremor. Okay. So when you hear the beep, her tremor gets quite a lot better. So that helps us map exactly where it is that we should put these electrodes. So in addition to that, I match the clinical work that I do with research in the same area. So the efforts of the lab are directed towards understanding how the brain is altered by the experience of pain. And my graduate students, and I think one of them is actually here, and other students that have been in the lab have worked very hard trying to understand these conditions, finding signatures for pain in the brain, and using primarily structural brain imaging techniques for that. And I think this in fact, the way that these two match each other, it's quite unique in the sense that we have the patients, and that helps us understand the problem and understand what it is that we need to address to treat these patients better. And then we have the research that really walks alongside of it in a parallel format to develop better methods and better ways of understanding this condition as well. And I hope that the way that these two match each other really allows for a faster progress in terms of what we can offer our patients and how we are able to bring the latest clinical treatment for their benefits. And again, research is super cool. We get to study the fibers of the brain, and as much as it's so pretty to look at this, really what we want is to take the MRI that I showed you before, and then just look at the fibers that are of interest to us. So focus purely on the trigeminal nerve fibers, their connections, and so on, because that is what we want to study. And move again from broader images to very narrow focus images. And for instance, this one showing some of the lower cranial nerves. And we match this as well with methods in which we are able to understand the gray matter of the brain by studying its cortical thickness and tessellating the brain in these tiny, tiny geometric figures, and keeping a memory of where are the peaks and valleys, where are the gyri and sulci, and how these might change in different conditions. So I'm super proud of the lab that I have. This was a few years ago when we had a solar eclipse. So we all went up to the roof of the hospital and put together a homemade viewer so that we could capture the solar eclipse and not go blind at the same time, both of which are important. And it's an amazing thing. And I think the third aspect of the work that I do is the area of education. So as time has gone on, I have become more and more involved in different aspects of education, but it all started really very, very early when I started my time as a staff at the Toronto Western Hospital with something that I had a huge appreciation and I should say a vocation for, and that was if we have someone that gets sick in Toronto, in Montreal, in Vancouver, we take them to good care, we give them good care. There might be some delays waiting for someone in the emergency room to see and so on, but nonetheless we have very high standards for our population. And why is it that someone in Africa or someone in Southeast Asia or someone in underserviced Canada does not have that? And that lack of equity always bothered me immensely. So I thought of different things that I could do to help that. And this is a chart based on some data from the World Health Organization, which was very impressive to me when I saw it, that the world richest third of our population gets nearly 3/4 of the surgeries that are available to it in a year, which means the rest of the world only gets 25% of it. So think of the lack of equity when we talk about this, and we consider, for instance, where's the other picture I had for you? When we consider the poor socioeconomic status that some places have with insufficient resources, and how this results in a limited capacity and infrastructure, leads to suboptimal neurosurgical care, and eventually results in decreased quality of life. And this whole circle feeds itself. So in many countries, when someone has, their means of transportation is a motorcycle, and more than one person are on that motorcycle, generally only one of them gets a helmet. It's unusual for more than one to have one. And you have situations like this all the time. Look at that young child. So if there is a car accident or a traffic road accident and someone gets injured, the burden of that injury falls not only onto the patient, but also onto the patient's family. And it ends up being a significant societal problem and community problem to look after people that have early injuries. So this took me to really, when I was a resident, my very first trip internationally, when I went to Calcutta. And you can see here, actually, this is the resting place for Mother Teresa. We actually got to see her houses and her orphanages, which are incredibly clean in the city of Calcutta. I don't know whether any of you have been, but it really is like a beacon of light. They're wonderful to see. And this trip that I took as a resident in 2002, here's a young me. It really was, it transformed a lot of my views and how I wanted to shape the future of my career. And this has now gone on with many other trips. This is another trip that I took to India. So this is actually AIMS, which is the All India Medical Institute in Delhi, which is the largest and very well recognized institution in New Delhi. And this is where patients are sitting, waiting for their clinic appointment. The inside is already full, so they're spilling outside and patiently waiting for their doctor to call them and see them. So it's really consideration for situations such as this and many other parts of the world that really has taken me to become involved in activities that are aimed to strengthening neurosurgical education worldwide, to create stronger programs and to provide a level of support and collaboration to places that want to have a greater level of care for their own patients. So this is a trip, I think this was now about 10 years ago, when we started the very first experience of a frame-based biopsy that allowed a minimally invasive approach to the treatment of patients in Africa. And this is a sizable tumor in an 8-year-old boy that, rather than doing a big craniotomy to approach it, we were able to just do a frame-guided biopsy, which is quite a lot easier. And then I started something called the Neuron Project, which stands for Neurosurgical Education with Universal Reach Online. And it essentially takes the format of a face-to-face classroom in an online format and provides the structure of a neurosurgical curriculum online. So there's a lot of myths about surgery in low and middle income countries. And one of the, in my view, one of the greatest myths is that people in low income countries don't really know how to operate well. And that is probably said by people that have not visited those places. They're amazing surgeons. They're very, very good surgeons because they know what their limitations are, and they've been able to circumvent those limitations to look after their patients. Also remember that patients in these areas oftentimes come quite late with advanced disease. So it's not the tiny tumor that comes to us and we take the patient to the OR. It's like, you know, the big tumor, the, you know, big potato that you have to, you know, very, very gently remove. So these are excellent surgeons. Perhaps what they don't have sufficient of is a structured curriculum that allows them with a more in-depth knowledge base of things that they don't necessarily have time to quickly look after. So that is where Neuron Project comes in. And one of the places where I set this up some years ago, and it's beyond any of my expectations, it's taken a very strong footage, is Cambodia. So Cambodia is a country that has suffered a lot after the Khmer Rouge really devastated the country and left it with a total of 7 physicians by the time they were done. It was a revolution of the farmers, and obviously the Khmer Rouge were communist, but anyone who was educated was essentially taken into the camps for work, and the country was left in a really terrible and devastated condition with these killing fields and the terrible atrocities that were committed. So eventually the country got itself in a position such that in 2013 it was able to restart its neurosurgery training program, and here I am with Dr. Vichet, who is my friend in Phnom Penh and the head of neurosurgery at the Priya Kosamak Hospital in Phnom Penh. And there, the residents just warmed up to the idea of the Neuron Project and took it quite strongly. And we were able to put together a 3-year curriculum to walk them through the junior years into their senior years, and help them with aspects of neuroanatomy, neuroradiology, neuropathology, and really the core curriculum that comprises the didactic aspects of surgical training. So these are some views of Cambodia. Amazingly wonderful people with very difficult circumstances. You can see that the people nursing the patients is the patient's family. So they bring the food, they look after the patients. If they're in the ICU, the family looks after the oxygen. And they do so, you know, oftentimes they have to bring the rest of the family with them because one person alone is not enough. And bed sheets are not often there. And really people go through quite a lot of difficulties, and it's very, very impressive to see how they take it. So last time I was there, we had a young boy, a motorcycle accident, came in with an acute subdural. They told the family that the patient required surgery. The family spent about 48 hours to collect the roughly $70 that is required to perform a surgical procedure. That meant this young boy sat around with an acute subdural for 48 hours until that money was collected. So his outcome was not good. So things like this happen every day all around the world, and these are the areas that I want to influence, so that when an acute subdural comes to Phnom Penh or an acute subdural comes to Toronto, they really fare the same way. And yeah, I guess these are some of the faces of the patients that I've seen and I've treated. This woman at the bottom right was one of the very first trigeminal neuralgias that underwent microvascular decompression when I visited. And this young boy was the son of a farmer in Phnom Penh, and he had a neck injury and was able to come to the hospital and get good care there. So did I face any roadblocks? Well, The saying is, if there's a long road ahead, expect many roadblocks and pack some snacks along the way. There is no other way, and it's just not neurosurgery alone. It's many specialties, even beyond medicine as well. If you have a long way ahead of you, you got to pack some snacks around the load. My recommended snacks are resilience and persistence. Resilience because, you know, neurosurgery, as I routinely say to our students and learners, neurosurgery is not a game of who wins. It's a game of who loses the least. So you have to accept that you will lose. You just want to lose as little as possible. So you got to be resilient. Sometimes terrible things happen, and just minimize those as much as you can. So that means having eyes at the back of your head and thinking 3-4 steps ahead to make sure that bad things don't happen. And you got to be persistent. You got to be persistent to want to get into neurosurgery. You got to be persistent when you're in neurosurgery, because boy, there's going to be plenty of things to encourage you to change your mind. So maybe you want to call it persistence, maybe you want to call it being stubborn, maybe you want to call it being diligent. Whatever your choice word is, you got to have it. And I think I'll close, since the International Women's Day, with saying that you have to have people behind you. This is my mother. As you can tell, I was probably, I don't know, 5 or something like that. And it was one of my birthdays. And, you know, young girls always have obviously a connection with their mothers, but they also want to be very independent. I think I was on the extreme independent side maybe, and I'm not sure how happy my mom was about that. But I have to say that my mother was a huge influence in who I've become. And she was an incredibly smart woman, way more than I could ever hope to be. But she never had the opportunity to use her intelligence because of life circumstances. Nonetheless, the influence that she had on me and the force that she was in my life was really instrumental for me to do what I've done. So I don't think that we, none of us are able to do what we achieve or what we think that we achieve just by ourselves. We are the products of our community and our environment, our family and our friends. And I think this is very valuable because, you know, the road does feel lonely sometimes, particularly when bad things happen, unexpected things happen. And that's really when we need those who are around us. So I think we have to value them a ton and really appreciate that all the hard work that we do, that all the decisions that I've made in terms of, you know, working crazy hours and so on. Obviously, those were my decisions. But the people around me that supported me and surrounded me, they never really chose that for themselves, but they helped me along the way. So they deserve a lot more credit than I would. So yeah, I think the rest of the time, I think we can just have a conversation and chat, and I'll be happy to answer your questions.
Well, first of all, thank you so much for that very inspiring presentation and for sharing your insights. Really, really wonderful. I'm sure I'm speaking for everyone. This was a really great narrative. Just one quick note. I put down on our chat a file. So if you could, everyone could put your name, email addresses for future events at CamSign, that would be really appreciated. We're going to go to the Slido in case people don't have access to it. We'll post it there. We have 23 questions so far. Feel free to add more. We will go in the order that we've received thumbs up. I think we're going to get more, so hopefully we can address all of them. So I'll begin with the first one and then we'll rotate. Okay, great. So the first question that has 10 thumbs up reads, did you ever hesitate to do neurosurgery based on the work-life balance or the fact that it is such a male-dominated field? The second question is, if so, how did you get past this?
Okay, so well, I should say, maybe I sort of said it a little bit at the beginning, that people choose their path in different ways. And I know people that said that since the age of, I don't know, 5, they wanted to be a neurosurgeon, and by God, they got there. I certainly was not that way. So I think, you know, this is very individual in terms of how people want to make their decisions. I think actually, men and women differ a bit in this regard. In my observation, it's just not generic, but just my own observation, because I think, at least for myself, I look at a problem and I look at the side and this way, what if this, what if that, and maybe that's not, for a while I would drive myself crazy and say, well, maybe I'm hesitating, but I think, I examine things in a different light, and I know many people that don't do it that way. So then when I decided to do neurosurgery, I spoke with a lot of people, and no word of a lie, for every 1,000 people that tried to change my mind, there was maybe one person that said, it's a good idea. And at the end, the two people that really encouraged me was my mentor, Dr. Talala, and one other physician who I know really well and I respect a lot. He's an ophthalmologist, and I had spoken with so many people, and everyone was very well-meaning, and they told me, it's hard, and it's crazy, and do you really want to work with neurosurgeons? They're just like, half insane, and on and on and on and on. And finally I said, you know what, I'm just going to call Dr. Smith. And I actually I remember my desk. I remember the moment I picked up the phone, I said, I'm going to call him. And if he says one way or the other, that's going to be it. And I called him and he said, no, you love neurosurgery, so you should do neurosurgery. And I said, okay, that's it. I'm doing neurosurgery. And everybody else that tried to change my mind and they said negative things about neurosurgery, they were all correct. Everything that they said was true. Was it hard? Absolutely. Were there days in which I said, this is absolute insanity? For sure. But that's why I say, and there were many times I had a senior resident, in fact, when I first started PGY1, and he used to say, if you don't think at least 100 times a day that you want to quit neurosurgery, you're not working hard enough. And I think there was a lot of truth to that. But yeah, you gotta have something inside of you that pushes you to do that. And eventually things change. You start as a PGY1 and you think, you've got this, and then you realize you're at the very bottom of a very long totem pole. And then slowly you get to that middle portion, and then slowly you realize that you are independent. And then pretty soon, things turn around and you're teaching other people how to operate. So, you have to persist and be resilient. And I think that is really true for a lot of hard things in life.
Thank you so much. Okay, so then the next question here has to do with the job positions that are in neurosurgery. So the question here is, do you still encourage students to pursue neurosurgery given the poor job market that is in Canada?
Well, I mean, we have two ways of looking at things. We can, and it's our choice how we do it. We can pick a career based on availability of jobs. What are the options in terms of the places that you might work and what advantages they give you and so on. Or you can pick something because you really, really, really love it. So if you can match the both of them, awesome, go for it. But I would advise you that this is really worth thinking about, because every surgical subspecialty, every medical subspecialty has aspects of it that you would think are not particularly fun. Maybe it's long work hours, maybe it's the type of disorders that you look at, the places where you're able to work, for instance. So at some point, once you're in that position, then you have to deal with whatever's your surrounding, and you have to get used to the group that you work with. And therefore, I would advise you to think of the pluses of a specialty. So if the pluses of the specialty of being working within the neurosciences, using your own hands and your technical skills to bring benefit to someone, taking the subset of a population that really most medical and surgical specialties say, I don't want to have anything to do with that, I don't understand it, I'm out. Taking those and helping them, if that is what appeals to you, the job will come. I don't think that is, I don't know of any neurosurgeon who is, not doing something that they really want to do. So I would not be particularly concerned. I think the specialty has to speak to you, and you have to see yourself fitting within the atmosphere of that specialty. If that is the case, honestly, I think the rest of it will just fall into place.
Yeah, thank you so much, Dr. Hodaie. So the next question is a bit of general and open-ended question. So the question is that, how do you handle failure in your profession? However you want to define the failure.
It feels like an interview. How do you handle failure? Well, from the very beginning of a neurosurgical career, we are taught, and you will be taught if you do it, or other surgical specialties for that matter, to deal with failure by looking at it straight in the eyes, and it hurts. So we have these rounds called morbidity and mortality rounds, where we take bad outcomes and we tease them up, and we figure out what is it that happened. And there is not a single instance of morbidity and mortality rounds, and how many years have I attended them, that you don't have something at the tip of your stomach telling you, what the hell? And, maybe it was your own failure, maybe it was someone else's failure. But I think learning to look at failure in the eye and appreciating the pain that it gives you is extremely valuable, because you don't want to experience that again. And that, I think, for me, has been the greatest lesson. And, we are only as good as our last mistake, isn't that the saying? So to remember your last mistake is how you don't do it again. And we learn from each other, we learn from our own mistakes. But yeah, that is, it's a sobering exercise. Favorite song.
Excellent. Next question. We're really glad that we're getting all the questions. And the next one, also with 10 thumbs up. What obstacles, if any, have you faced as a woman in neurosurgery in Canada?
Okay, so, I mean, people are made in different ways. I have always been so naive. And I've thought, life is merit-based, etc. And then as I got into medical school and then went on and so on, got into neurosurgery. So I figured, but then, as time goes on, you actually do start seeing things that are very different in certain circumstances. And it's not, well, I mean, from my perspective, you have to be brave, you have to call it, and you have to stand up for what's right. You also have to look for people that you trust and that will back you when needed. That's easier said than done, honestly, because, circumstances can vary depending on what the issue is and what the specific point is that one needs to address. But I think, I have tried in times sometimes it's really worth it to jump up and down and make a point. And sometimes it's worth it to wait a bit and figure out when is the right time to say something or to do something. So that, I think, is the element of wisdom and the ages, the years that you pack under your belt that help you understand things a bit more clearly. and looking at, keeping your eyes open, looking at the horizon, see how people do things and what are the reactions and what is it that happens. Have I seen injustices in my days? Yes, plenty. Have I been able to fix everyone? No, and I have to say sometimes you know that you can't fix it and you just say, you know what, this I can't tackle right now, is just not the right circumstances for it, and I'll come back to it at some point. So it's not every single problem that can be solved, but I think recognizing the problem is a hugely important task.
Thank you so much for that answer. Okay, so the next question we have is about families having a family, while being a neurosurgeon. So the question asks, could you speak a little bit about, being a mother or starting or having a family as a staff neurosurgeon?
What would you like to know? So yeah, I have two daughters. My first daughter was born actually when I was in residency. I was a PGY4 when my oldest daughter Sarah was born, and that was a hard decision. I thought about it a lot, and I said, you know what, this might very well be career suicide, but let's just see what happens. And I guess it wasn't at the end. My second daughter was born about 6 weeks after the Royal College exam. So I did the fellowship exams heavily pregnant. And I guess that gave me a wild card. I figured if I do really poorly, I'll just say I've gone into labor and someone will come to my rescue. But I think it was okay. Yeah, it's not easy. I think, I really had to juggle so many things at once. I think for my own thinking, what helped me a lot was to really have people to help me. And for me to just ease my mind into not wanting to do everything for everybody. Still, even though I ease my mind, I still have to be in control of certain things. But I've been the routine parent that keeps getting the email from the principal saying, you're yet late again with another form that you haven't signed or something like that. But I don't know, we managed through. It's we have our moments. I think as a resident was a lot harder actually to have a when I was senior resident, my daughter was 1. That was really, really tough because sometimes I would not see her for like days. But I'm very lucky. We're very close as a family, and even though they're not particularly interested in the field that I work in as a profession, and neither of them have gone into the medical field. Nonetheless, there's quite a lot of cool things that I think they see in the work that I do, and I hope that at least I have allowed them to see that having a passion for what you do is really the crucial thing. Honestly, I don't think it matters if you decide to be a neurosurgeon or whether your passion is fine arts or poetry or sociology or whatever it is. As long as you truly, truly find, in my view, 2 principles that you apply to your work. Truly a passion, and second, a desire to help society. So if you pick anything that you think, this is my skill and I can apport my skill to help society at this level, then, what else can we ask for in life? We each have our own set of, attributes and skills. And hopefully I've been able to impart that to my children as well.
Thank you so much. Hopefully you're not tired yet. So the next question we have asks you, at what stage in your career did you realize that research in academic medicine was the right choice for you?
Probably later than I should have. Time changes. I think right now for people that are considering even applying to neurosurgery, they've already played in their mind how they will set themselves so that their application is ideal. When I was at Queen's, I mean, yes, I had experience and interest, and that obviously allowed me to do a lot, but it was not as perhaps crafted as it is in 2021. Nonetheless, it's something that well within the realm of medicine and or medical school, at least, there is a sufficient time for one to think of how to do, how to put your own interests and in what you're able to craft for your career and so on in place, so that it develops into something that is solid and self-sustained. Perhaps it's a good place to intersect a concept that I have surprisingly come across again and again and again and again, and that is, for me at least, it's applied so many times in my life, is the concept of serendipity in science. I did my first degree in biochemistry. We used to have a biochemistry teacher that, I mean, I don't know, I never warmed up to the guy too much. He was a little bit too authoritarian for my taste, but he always said this thing about how much there's so much serendipity in science. I just like, rolled my eyes at him. It's like, seriously, like I'm going to go by in life and just wait for something to land on my lap out of serendipity, and that will be my science. Like, what are you talking about? But then, as life has it, so much of my research has been, in fact, shaped by serendipity. I first, started doing shaping my own research in a field that I still continue, with research in neuromodulation for movement disorders and so on. And then I became involved in these advanced imaging techniques, primarily for the purpose of identifying the brainstem pathways that were very close to the areas where we were putting our deep brain stimulating electrodes, so that we could visualize them better. And I still remember I was working to give a talk, and it was sort of like, I don't know, pretend it's today, and my talk is at 7:30. It was like 4 o'clock in the afternoon. I was trying to get the best pictures I could get for this talk, and I kept playing around with the region of interest to see whether I could get these fibers, and they were just not coming out right. I was getting so frustrated. I had so little time. I said, okay, I'm just going to put this ROI in a place where it's sort of safe, and then walk my way towards the brainstem. I put it somewhere, and the tracks the tracks came up, and I looked at it and said, that looks like a trigeminal nerve. And I mean, that just completely changed the direction of my research, like literally 180 degrees. We had never imaged cranial nerves with tractography before, and I was starting to do more and more patients with trigeminal neuralgia, and the image of the tracks that I developed at 4 o'clock in the afternoon, which I did not include in the talk, just stayed in my mind, and I kept thinking about that again and again and again. And then, that the whole field, I mean, I've essentially minimized my work in imaging of the fibers of the brainstem, and went on to really develop the, I would say, most advanced way of imaging the fibers in trigeminal neuralgia, and all the results and the interesting findings that we had on from that. So that's just one aspect of serendipity. So I would say, plan your research, plan to see what it is that you like to do. But for me, serendipity is not that suddenly life gives you a gift and you're just there to grab it. Is the possibility of seeing opportunities that come to you. And sometimes when I think about it that way, so think about the serendipity of me connecting with my father's neurosurgeon. Who knew, right? That's an opportunity that life gave me, and I took advantage of that opportunity and used it to understand more what that field was like. Sometimes I wonder how many other opportunities did life give me and I did not see it, and I did not use them. It's quite possible as well. But at least if we have an open mind and we're able to see the value of opportunities when things that we don't quite understand suddenly come to us, study them, look to see what context they might play as they appear. Those are amazing things, and really good science happens with that. I I'm not of the type of a scientist that asks one question and only one question and will not move their gaze until that question is answered, because I think you actually do miss quite a lot of things along the way. Some people are like that. I think we need everything in life. That's what has worked for me. But yeah, I have to say, I keep thinking of that biochemistry professor back. I can't remember his name now, but he was right.
I'm sure he would remember your name, though. Great. More questions. I'm sorry, but there's so many questions. If you ever get tired, please let us know. But to make it efficient, I'm going to try to put 3 in 1. It's about mentorship. That's the theme. So some people are asking about specific advice if it's hard to sort of foster this mentor-mentee relationship. Another question is about advice when looking for mentors. I think those were the main themes of the questions. And how do you ask people, how do you approach them to be your mentor?
So I should say that mentorship is now a very big and well-recognized field. It was something informal, and I mean, when I was a student, you would not walk around saying, "Oh, I have a mentor." Now it's perfectly okay, and in fact, advised that you have a mentor. So there's a few people that have taken on as their life's goal to study academic mentorship and how that takes shape. So you should perhaps maybe read up on that, whoever is interested, because I'm myself learning quite a lot in that process as well. A mentor really should be someone that you either approach from a professional perspective or a sort of a little bit broader than that in terms of not just professional, but also, what that person's attributes and personality and characters are. I look at the mentors that I've had in my life, and I have not had one. Perhaps I would qualify it as like maybe one big mentor, Dr. Talal, that I already talked about, but he's not the only one. There's other people that have influenced me tremendously. And I must say, there's people that still to this day, when I do certain types of operations, I still hear their voice in my head and how they say, don't do this or do that or something. And, their presence is very felt. And what are they but mentors to me, at least in a specific realm of the work that I do. So, we see different attributes in different people that we connect with. With some people, we might connect intellectually and be very much drawn with how that person thinks and analyzes something. So that's, I would say, one type of mentorship. With some people, we connect more on a personal level. There's something about that person that is attractive to us, and we feel that we connect with them in terms of who they are and how they go about life, and we learn and enjoy that attitude and behavior. And I find that heartwarming and refreshing, in fact, to see that there's someone that you sort of see, so you know what, 30 years from now, I would like to go by life just like that person. So there's many different attributes, and I would advise you to look at all of them. Don't park yourself in one spot alone. I think, as medical students, as, future residents, future health practitioners, as undergraduate students, feel free to approach people and, I don't know, if you want to send an email to someone and say, would you like to be my mentor? Maybe, it sounds perhaps a bit unusual, unless you are in the same faculty and you get to meet face to face. But nonetheless, you can connect with all kinds of people and run things by them, ask for their advice, and see whether you can establish that connection with that person. Sometimes we're surprised. We think that, I really like that person, talk to them for 5 minutes, like, maybe not. And the reverse is true as well. Some people you sort of are forced to work with, and a little bit of time passes and you really connect with that person. You sort of do speak the same language. You didn't think so at the beginning, but it doesn't necessarily continue that way. So allow yourself the opportunity to explore, to connect with people, to talk to them, ask for their advice, ask for their thoughts and opinions on things. if there's a specific project you're interested in, for instance, research or education projects and so on, ask to participate and see how they behave, see whether they reciprocate and they're also interested in you. So generally, at least in the education work that I do, the advice is that the mentorship relationship should be driven by the mentee. And the mentor should obviously help and assist that relationship. So see how that works for you. If your mentor does not cooperate, then maybe they're not that good of a mentor. Test them out.
Yeah, and actually about seeking advice, the next question here is, and I'm sure you probably spoke to it to a degree, but the next question is, what kind of advice would you give to younger you about pursuing neurosurgery?
Younger me, oh my goodness. Honestly, this is like an interview night. Let's see. Well, I think I would say less hesitation. I think I hesitated too much and I kept thinking about things back and forth. Should I do it? Should I not? There shouldn't be that much hesitation. I think we need to see our own strengths, and we need to be aware of what we like and the value of knowing that you like something. It's so amazing for me to realize, to actually know that you have a passion for something is so valuable. So why disregard that and doubt yourself? To some level, self-doubt, I think, has a role in our lives. Like if we don't doubt that maybe this step is way too high for me to jump, well, there's a way of finding out the answer, right? So self-doubt is good, but I think too much self-doubt is detrimental. So yeah, maybe I was too hesitant or too perhaps cautious, but yeah, beyond that, I think every time, in my view, action is definitely better than inaction. So if you think you got to do it, just do it. Don't wait.
Yeah, thank you so much. So let's change the gear a little bit. The next question is about bread and butter of neurosurgery. So the question reads, can you comment on the bread and butter of neurosurgery, the most common procedures the students do in residency and throughout their careers?
So I guess my work does not count to be bread and butter. My work would be I don't know what I would call it, but the vast majority of neurosurgical cases in terms of percentage of cases that get done are spine and also malignant tumors. So obviously metastasis to the brain or spinal cord, but definitely degenerative spine is the most common. And it comprises a significant proportion of surgical cases and clinic visits and referrals. If you are in an academic center, for instance, where we are, then that is completely skewed because we are very subspecialized in our fields, and therefore we strictly get referral for the vast majority. For the most part, we get referrals within our own field of subspecialty, so we triage them to different people, and even then we narrow them even further. So we are not a very good representation of the bread and butter of neurosurgery, even though we see them. So when I'm on call, obviously things come to us such as conditions that have to be looked after either right away or within a few days and so on, and I'll look after them with pleasure if I can, or if they're very subspecialized, pass them to someone else. So for instance, we have a team looking after aneurysms and AVMs, we have a team looking after complex spine, But if I'm on call, like for instance, 2 nights ago, I was on call, we had this very interesting case of a patient who had spinal fusion with a plate that was put in his neck maybe about 10 years ago. And he just missed a few steps. He fell down. He was perfectly fine. They did an X-ray though to be sure. And the plate that was affixed to his vertebral bodies 10 years ago with 2 screws at the top, 2 screws at the bottom screws are missing, and the top screws are, and the plate have completely lifted and are floating, and it has eroded through his esophagus. So this is a very unusual condition that can happen, and I'm looking after him. I mean, you know, it's not quite bread and butter, but we have to obviously be neurosurgeons first before we are this subspecialty entity, and therefore that means looking after all kinds of stuff. So this is actually a value. I think the whole of medicine needs to be in the armamentarium of a surgeon. A surgeon cannot be a good surgeon without being a very good doctor first. And that this is important. So keeping up your medical knowledge, keeping up your general neurosurgical knowledge is crucial. And I hope that it remains for me at least as long as possible.
Excellent. Is it okay if we continue? Please let us know whenever you're tired too.
Go ahead.
Okay, we have, I think we'll go do a more technical question. Could you share some insights on functional outcomes for trigeminal neuralgia patients post-decompression surgery? How has it changed over time?
So microvascular decompression has the greatest likelihood of providing pain relief after surgical treatment. And upfront, I quote patients a 90% likelihood of them being pain-free. That means 9 patients out of 10, which is really the best numbers that we have. I think, you know, the way the surgery is performed has not changed much, safe to say that when Janetta, when Janetta first started many years ago, obviously imaging was not as good as it is now. So CTs and MRIs slowly came into the field, and that's obviously great. What's changed though is the surgical approach. And I should say that when I did my very first clerkship elective, and so the way it happened at Queen's is that we started clerkship with our electives, and therefore my very first clerkship elective was a neurosurgery elective. So I started doing a neurosurgery elective somewhere. On it, no word of a lie, I didn't even know how to write a Tylenol order. So I mean, that was like trial by fire. But it was probably the second operation that I saw was a microvascular decompression. Beautiful anatomy. I mean, you could see the whole of the posterior fossa, the cerebellum was exposed right down to foramen magnum. That was like a 6-hour case, you know, to have that full exposure and so on, because a very limited microscope visualization. So you had to have a big exposure. Now with obviously the use of a microscope as well as neuronavigation, my incision is this long, and the case is done in an hour and a half. We go very targeted just to the trigeminal nerve. We don't need to expose all the way down to, you know, the bottom of the spine in order to see that well. So I think that has actually improved the recovery of patients because they're home in 2 days, and they do really well. They don't have these super long incisions with neck pain after, and their recovery is so much better. So beyond that, obviously, the rest is just, you know, good surgical technique. And that, of course, is not unique to me. There's many wonderful surgeons there, but really the targeted treatments and targeted surgery that we are now able to do with neuronavigation has resulted in tremendous functional improvements for patients.
Thank you for that. Okay, so I guess I'm just going to be resolving some of these questions because these have already been answered. And I guess the next one here is regarding like international work, actually. So it reads, so this person's asked, with your international experience, how would you compare the available opportunities there are for women in neurosurgery compared to higher income countries?
I'm not sure if I understand the question, Pedro.
I think what they're trying to ask is, with respect to the opportunities that are available for women in neurosurgery, how do they compare in like internationally in different countries compared to higher income countries,
Oh, I see,
like in
Okay.
Canada or US or in Europe?
Okay. Yeah. So whether there is a difference in terms of the likelihood of a woman being in neurosurgery in Canada versus some in a low-income country, for instance?
I think so. Yeah.
Yeah, that is quite variable. It's a very interesting field of study and understanding, I have to say. I mean, the vast majority of the world, in fact, save for one country, as far as I know, is quite male-dominated in neurosurgery. Canada runs about 10-11% of neurosurgeons are women. US, I think, roughly the same. Algeria, of all places, has a very high percentage of women, like solid 70%, and I've met some of them. So I don't know why they have managed to have this high levels, which is great. But I don't think this is truly representative, of course, of the rest of the world. With a low percentage of, say, 10-11% in Canada, then the other places are also low or lower. In most of the countries that I've visited in sub-Saharan Africa or Southeast Asia, I have not met any women that have been neurosurgeons, save for one resident that is part of the probably at this point middle tier in Cambodia. We have had a number of women from the Middle East that we've trained. They're not low-income countries, but still from that society is unusual to have women, particularly from Saudi Arabia. Fantastic surgeons, very, very strong. They've had to deal with a number of challenges in terms of allowing or having sufficient backing for them to be able to do what they do. So very, very strong women. Yeah, I don't know that there's one can ascribe a specific be prescriptive to one society is one way, another society is a different way. I think we are who we are with our context, and I think in the context of women in surgical specialties, we really are still a minority. A lot of surgery goes back to the Victorian times. If you have not read a book, I just came upon it very recently, called The Butchering Art, which is about surgery in the Victorian era, by an author by the last name of Fitzsimmons. And she actually spoke at our Department of Surgery rounds very recently. Absolutely fascinating account of what surgery was like in the Victorian era. So I think if I was there 150 years ago, no way I would have been a surgeon. Absolutely not. So, but things that change, and I think we are actually seeing from looking at or reading this book and seeing how much surgery has changed. What's changed? Obviously, antisepsis has changed. Anesthesia has been advanced, which is fantastic. But I think we have also introduced a significant degree of humanism in how we deal with our patients in medicine in general, and also with surgery. Now, does that come with more women in the field, or does everything just go together? Whatever it is, I think we're going in the right direction. So I have to say, I'm not so picky on percentages, because what does 5% versus 10% mean? They're still small. It still means that we're a minority. but I look more at the track that, where's the road going? And if the road means, greater level of humanism, greater level of inclusion of minorities, of women, really recognizing that everyone in society has something to apport, and we are all stronger when we work together. That's really what matters, and that's I think where the world needs to go. So that occurs obviously at different paces in different societies. Even within our own society, there is not sufficient equity. Things are not the same in Toronto as they are in Iqaluit. They're not the same in Saskatoon as they are in Newfoundland, maybe. So within our own society, I think we can explore that as well as exploring it internationally. I think we also have to be cognizant that people also fight or address different problems within their own societies and within their own context. So, we have to be very careful. This is something that I also learned early on about not going somewhere and be prescriptive and saying, oh, hello, here I am, and you need to do this, this, and that. That really doesn't work. We have to understand that we can share and we can collaborate and we can provide our ideas, and they will warm up to some ideas that might speak to them and may not warm up to some others because either it doesn't apply to them or they don't see the value of it at that very time. Maybe they'll see the value of it later. Maybe it's me that's wrong, and I think that they should see something, and in fact, that's not the case. So, it's when the time comes, change will happen, but I think we have to accept that it doesn't necessarily happen at the same rate in every place.
Thank you so much. So next question is actually talking about the COVID condition we are living in right now. So the question is that what challenges has the COVID-19 pandemic introduced in the OR?
Well, I mean, let's just say it hasn't made things simpler. We had to stop operating for quite some time, and then we ramped up, and then we ramped down again, and we have to be very careful. I'm the site director for a residency program, so I have to, in addition, have an eye to make sure that our residents are safe, that they're protected, that they have the appropriate equipment. Our patients need to be tested, obviously, before every procedure, and sometimes the test doesn't happen in time. Then the case gets canceled. There's a lot of things. I think I have to say the residents have been absolutely outstanding in having a really, really good attitude and taking on an added challenge of uncertainty. I mean, you go to emerge and then you think everything's okay, and then tomorrow you get a call saying, oh, you know that patient that you saw? Well, he has COVID. It's like, ah. So things like this happen all the time. So it really has complicated our lives by many factors, I would say.
Okay, great. So let's do one more question. I know it's been a very long session. So the final question for the night would be, how can we create sustainable changes in the medical landscape on trips abroad, and how do you empower locals?
Very good question. I'm almost ready to pull up a full PowerPoint presentation to talk about this. Okay, so I think whoever asked this question is a very astute person, because it speaks very much to the point that trips abroad are not always sustainable. This was one of the reasons, in fact, why I thought of other avenues of being more engaged in global neurosurgery, because I was not in a position to travel as often as I wanted to these countries, and on top of that, have my clinical practice and have my research, priorities, and somehow come to the house once in a while. So it just did not seem sustainable to me. And look at it from the other end. You're in some center in, I don't know, let's come up with a country at random, in Southeast Asia. And this very well-meaning neurosurgeon says they're going to work with you, and you see them for like the whole of 2 weeks a year. How effective is that? When I was in Ghana, in Africa, we're going back a few years. This was something that I thought about a lot, and as I was thinking, a team of physicians came, of orthopedic surgeons came from the U.S. And they came, we had gone there to, I showed you how we were started to have the frame-based approaches for biopsies, and we were working with them to, we took a frame and, got things started there for them to work with it. And then this team of orthopedic surgeons came in for scoliosis corrections, and they brought doctors, nurses, electrophysiologists, cell savers, like every single bit of a neurosurgical, an orthopedic surgery or in the US was just brought there. And they would stay for 2 weeks, operate on about maybe, I don't know, 40, 50 patients, and then leave. So there was quite a lot of thoughts going through my head saying, is this reasonable? Should this happen? The locals are not really learning. But then, there's a bunch of kids waiting for surgery that if it wasn't for that team, it would not happen. So there was a lot of struggle of, are these trips sustainable or not? So then I figured for myself that my efforts should go into residency education for 2 reasons. They are the upcoming crops, right? If the residents are strong and they feel strong in their own learning, and they don't feel that that they are less than they would want to be, then they are the ones that will allow the subsequent teams to remain strong. That was item number 1. Item number 2 is that in most countries, and I'll add Canada there as well, there's a lot of inter-relationship politics of, I do this and I have this relationship and so on. And I did not want to have too much with that, and I did not want our cooperation with other countries to be perceived in that way. So I decided to focus on residency education and to develop a format that would allow me to, in fact, be connected with them all the time. There was no geography was not a barrier anymore. Through our online curriculum, I would be in touch with them, sometimes daily. And this is how I feel that collaboration is at its strongest, because you are able to help them through a case, you help them discuss a case, you help them with things that really matter in their day-to-day looking after patients. And then, that was added to like 1 trip per year, which solidified what we had learned. It was knowledge reinforcement, workshops, and so on. So I found that worked really well with me. And little did we know in 2020 that, virtual was the way to go. So this I think will be something that we will continue. It doesn't really take the place of a face-to-face meeting with someone. So it's not one versus the other, but I found, at least for myself, that the best way to making these trips sustainable was to match them with something that would eliminate geography and would allow that continuous connection with the site that would pair with.
Great, thank you so much for answering all of our questions, Professor. We really, really appreciate it. I think at this point we have tired you out, and it's been
I'm happy to speak with you. I think it's I have to say, it's really, really nice to have these essentially open conversations where people ask questions, and we just get to chat, and it's really good.
Absolutely. And we just wanted to thank you so much, Professor Hodaie, for joining us again tonight to share some of your incredible journey to and in neurosurgery, and shedding some light on the important role that women play in surgery, specifically neurosurgery, research and leadership. And at the same time, thank you so much to our wonderful participants for joining us tonight. We really appreciate the great turnout that we had. And we look forward to, with Professor Hodaie's permission, to post this recording on our website so that it is also accessible to others who unfortunately couldn't join us tonight. But I wish you all the best. Thank you so much for joining us again. And again, Professor Hodaie, we really appreciate it. Thank you so much.
Thank you, everyone. Have a good night.